So I'll introduce our next speaker, Michele Castonguay. She began her career as a sleep medicine technologist in 1988. This early entry provided unique opportunities to grow and contribute to the field. While at the Ottawa General Hospital's Sleep Disorders Clinic, she also co-created and led the Ottawa General Hospital Sleep Technologist Training Program. That's a mouthful, Michele. Over its
Sorry.
10-year span, the program trained nearly 100 technologists from across Canada. She's also served on the board of registered polysomnographic technologists, another mouthful, holding roles as secretary, examiner, and exam development committee member. More recently, Michele splits her time between clinical work at the Ottawa Hospital's Civic Sleep Disorders Center and her role as a clinical research assistant under Dr. Judith Leech at the West Ottawa Sleep Center. Her favorite part of the work remains her direct interaction with patients, and she's a strong advocate for patient education, believing that empowering individuals through initiatives like sleep hygiene is essential to therapeutic success. So thank you, Michele, for being with us today, and we will start just a smidge ahead of schedule.
Hello. All right. Thank you. This has been great. Wonderful presentations that I think kind of all dovetail together in a way. So this is good. I'll get on with it because I have more mouthfuls to share. All right. So let's see if this works with my screen here. Okay.
All
We're
right,
good.
over to you. Yep.
Awesome. All right. So it's kind of a big topic, each one on its own, but we'll see how we can get sort of a discussion going about how they kind of intersect. I mean, really, sleep hygiene kind of is affected by so many things. But all right. So basically, I'm going to kind of try to build a case for why, typically we treat sleep disordered breathing with CPAP or whatever, and go from there. But there's a good gang of folks that also have sort of either a primary comorbidity with its primary insomnia, or perhaps it kind of develops alongside of the other sleep disorder. And, it's a good case for, treating, sort of seeing the patient in a more holistic way and kind of treating the insomnia issues that can tend to come about and typically will improve how they accept therapy for everything else. Okay. All right, so just quick review of what is sleep. It's just a behavior and a process of rest and recuperation. Essentially, during the night, we cycle between non-REM and REM sleep. Non-REM sleep, if you can see from the staging stuff here, basically the more awake we are, the faster and lower amplitude the brain waves or EEG is. And the more deeply asleep we are, the slower these waveforms get. So here's wake. Stage one, it starts to break up a little bit. Stage two is kind of intermediate. Stage one is kind of more the introduction to sleep or the gateway. Typically, if we're sleeping well, we're not there for too long, 10% of your night. Stage two is sort of intermediate sleep where we're a little less rousable. There's still mental activity going on in the early stages of non-REM, but just, maybe a little more, the thoughts kind of take off a tangent. In stage two, they're kind of just sort of more plodding and very, thought-like, but in kind of a boring way. Usually, if you wake someone up from these states, they'll report some kind of mental activity, basically. As we get into N3 or stage three, there's a lot more slow wave activity. And that's the stage of sleep where if you wake someone up, they're very confused. They don't really remember much of what's going on. People who do things like sleepwalking and stuff, typically it's from that stage of sleep and they usually don't remember what they do. REM sleep, the brain waves kind of get fast again. There's a lot of mental activity going on, kind of fantastical dreams and so on. And the reason I'm just sort of focusing on that is that people that have any kind of sleep disorder where they're waking up a lot, uh, if you're close enough to wakefulness, you may not even feel that you've slept at all. And that'll be important for how this kind of comorbid insomnia kind of develops. Down in the bottom here, we've got what we call a hypnogram, which is basically a plotting of the sleep stages over time across a typical night. So this would be a normal sleeper, and you're going to get cycled down to, oh, well, this is an old an old hypnogram. Stage four is now just lumped in with stage three, and it's all called N or non-REM three together. Anyway, the first half of our night is more spent in stage three or deeper sleep, and the second half gets traded in for more REM sleep. But essentially, across the night, they sort of cycle. Um, and in REM sleep, the physiology, oh, well, I should say breathing is a little bit more unstable in the lighter stages of sleep as we're shifting in. And then it kind of settles down and becomes very much more at its most stable, I guess, in the stage N3, and that's when we're again least arousable and stuff, and everything, heart rate, breathing, everything kind of is nice and stable there. So if you can get there, great. And in REM sleep, it's a little bit all over the place. During the rapid eye movement bursts, actually the phrenic nerve is inhibited briefly. So the breathing, we'll see even in normal people during the rapid eye movement burst, the breathing will kind of get shallow briefly. So um, in the normal person, it's not a big deal. Um, and that's what I wanted to say about that. Oh, yes, in REM sleep, we are also losing a lot of accessory muscle tone for those who need it for breathing. A lot of our skeletal muscles are kind of paralyzed on purpose in dream sleep. We have a sleep disorder where some people that doesn't happen like it should, and they end up doing some dream enactment. But otherwise, yeah. So again, in the normal, regular folks, that's not a big deal. But if someone is using a lot of accessory muscles to breathe, then we have a problem when they hit REM sleep. So that's usually the second half of the night. And those folks that are either they have neuromuscular disorders or COPD or yeah, even just abdominal obesity. They're having all that extra weight to kind of move. These things will make them a little more impaired in REM sleep, and they're more often likely to wake up with headaches or wake up a little too early and then not be able to get back to sleep or not want to go back to sleep. Okay, and there we are. Page down not working now. Oh, why? There. Oops, I went too far. All right. So sleep is sort of thought to be regulated by what we call process C and process S. It's kind of described as homeostatic and circadian factors. So the amount of time we spend awake is going to build up more pressure eventually to finally get to sleep. So that's the homeostatic part. And then at the same time, there's also a circadian effect in play, and that's a time of day pressure to sleep. And that's more based on an internal clock that we have that is sort of responsive to the environment, but at the same time, will it operate endogenously, even if you're in an environment that doesn't tell you what time it is at all or anything. So there is a certain times of day. We might be really, really sleepy and then kind of get a second wind at some point, and that's the circadian aspect kicking in. Okay. All right, so the master clock that controls a lot of biorhythms is the suprachiasmatic nucleus, or SCN. Basically has a lot of information coming into it from different parts of the body and a lot of information going out to regulate various rhythms. There we go. All right, so the suprachiasmatic nucleus is right over here in sort of the hypothalamus area. There are some cells in the retina that are sensitive to blue light specifically that will communicate that to the suprachiasmatic nucleus. So it's kind of basically enables it to entrain the body to the light dark cycles, the outside world. And the suprachiasmatic nucleus also talks to the pineal gland, which produces melatonin. So if there's not very much light at all in the environment, the pineal gland will produce melatonin, which makes us feel sleepy, and no doubt is involved in a variety of other things. But if you're exposed to a lot of bright light, like in the daytime, the production of the melatonin will be suppressed. And it's this rhythm is sort of phase sensitive. Like if you could present a lot of bright light to someone in the middle of the day, it's not going to make as big a difference in terms of sleep and wake patterns. Whereas if you are exposed to bright light in the morning, that kind of tells your brain, hey, this is the start of the day. So let's, back up the clock a little bit so that we go to bed at the right time. Because inherently, if you put someone in a cave with no time cues, the circadian rhythm's a little bit, for most folks, a little bit longer than the actual 24-hour day, but that gives us that bit of flexibility that we can expand it, contract it a bit with as the seasons change and things like that. Although there are some folks where it's a little shorter than the 24-hour day, other folks it's a little bit longer. So you might have these phenotypes, if you want to call them that, of circadian preference, your morning people and your evening people. Okay. So this is just a little graphic to show that there are different rhythms that operate within the context of the sleep-wake rhythm, and they may not necessarily follow the same phase, but there's usually a kind of a harmonious relationship where if somebody's a little bit knocked off its block with respect to the other guys, there could be some consequences or things don't function as optimally. But where is this cortisol? Melatonin, yeah. So we'll see melatonin kind of rises in the evening, and then we kind of be going to sleep around then, and then it'll drop in the night, and then we wake up. Okay, this is just an example of things getting out of alignment. In this instance here on the very bottom, the person is put into a forced desynchrony protocol. So they're being put to sleep a little bit further and further from the usual spot. And the thing being monitored is leptin, which is a hormone that allows us to kind of regulate our eating, makes us feel sated. We don't want to eat anymore. And this is sort of a lot of different hormones are released at various rhythms as well. So the black one is the current while the person's undergoing the protocol. And as their sleep is becoming more and more misaligned to a maximal point here from where it usually is, you can see that the where the leptin should be up here is now lowered quite a bit, maximally where the sleep is maximally most, 12 hours off kilter. So there's a lot of research going on into the metabolic effects of circadian misalignment or sleep deprivation as well. And there's a lot of the metabolism of the digestive system and various hormones and things like that are affected. And there's a higher chance of obesity because of sleep debt and circadian rhythm mismatch. Shifting the internal clock, again, there's a phase and dose responsiveness to it. How much sunlight in the morning, but in the morning will shift your rhythms more, or in the evening, it will also push it. So if you have a lot of bright light in the evening, you can sort of delay your sleep-wake rhythm, which if you don't want to do that, is not a good idea because you'll end up you'll still all the other rhythms will be out of sync, and then you'll still wake up earlier than what you might otherwise need, and things start to happen where you get sleep deprived and develop what's called a sleep debt. Typically on its own, you can shift it naturally about an hour a day. And everything kind of goes together. Sometimes physicians might prescribe a bright light therapy regimen or use of melatonin supplements. And that's something that, should be done under the advice of the physician because depending on the person, it may not be a good idea. Sometimes melatonin can make some people feel depressed. Bright light therapy for some people might actually induce a manic episode if they're bipolar. So you don't want to be just messing around with that. Let's see. Yeah, so to shift the internal clock, it's very easy to uncouple rhythms if you were doing extreme things like shift work. And there's jet lag, rapid travel. There's a thing called social jet lag where you kind of go to bed later on the weekend and then you have the Sunday night insomnia. So you're kind of just your regular activities kind of get you slightly offset. And then there's how your regular life interacts with your chronotype. So if you're an evening person, but you've got a day job, you're going to probably get a little sleep deprived if it's difficult for you to kind of align yourself. Um, and even artificial light, ambient light's been shown to shift the rhythms a little bit. And more recently, focused blue light, like multimedia, the phones in the bed and things like that have really shown to be an issue in terms of affecting sleep and the onset to sleep. Sleep disorders themselves can sort of impact the circadian rhythms a little bit, and I'll show you a little bit about that in a minute. Inconsistent sleep habits, so poor sleep hygiene will definitely do that as well. If you're going to bed really late, staying up late, seeing bright light, well, that's going to mess up your sleep habits based on how it affects your melatonin suppression. Okay, sorry, keep losing my page down key. All right, let's see. So there's been a study more recently showing that obstructive sleep apnea itself can lower the person's overall melatonin levels. So let's see, the ones with the little square here is a light degree of or a mild degree of obstructive sleep apnea. This one in the triangle is moderate, and the bottom dark diamonds is someone with severe sleep apnea. And the top one is I guess, the normal, what the average melatonin secretion should be. Whoops. Where was I? All right. Yeah, one thing I wanted to say about that is there was another study, again, well, not so recent, but even just lower melatonin levels in general make it easier to shift them. Okay. So sleep debt is kind of a term that's been coined to just basically when you are deprived of sleep, it's very difficult to kind of pay it back because if you go to bed, okay, I'm going to go to bed, I'm going to sleep in longer, because I went to bed late. Well, if your circadian rhythm's not quite aligned with that, otherwise, it's going to wake you up earlier anyway. So you end up owing sleep-wise. And sleep debt itself, sleep deprivation, even if you're keeping your sleep habits in the right spot and everything, that is also associated with some metabolic changes that might lead to more obesity, which if you already have sleep apnea will make it worse, or it may influence your the development of it. So kind of a bidirectional relationship, really. Okay. Oop, there. This is just a quick thing to review obstructive sleep apnea. I'm talking more about that, I guess, but central sleep apnea also has a place here, and I'll get to that. So the pathophysiology of sleep apnea is pretty varied. It can be craniofacial abnormalities, pharyngeal airway abnormalities, just their sleeping position, depending on that. So, and often an interactive effect, I think. And I find a lot of younger people that come in that don't seem to have any of these issues and are thin. Sometimes just a prolonged history of nasal obstruction seems to be a part of their picture a lot of the time. So yes, the soft palate for a variety of reasons, and the tongue perhaps falls back and blocks the airway or partially blocks it. So here we've got a nasal airflow signal, and there's an apnea because it stops for at least 10 seconds, but the movement of the chest and abdomen is preserved. So your brain's still trying to make you breathe, but nothing's getting through. And at the end of this event, now we also look at even just reductions in the airflow. That's a discrete event, and those are called hypopneas. They will result in the same EEG arousal or speed up of the brain waves. So you're not getting a continuous restorative sleep. And sleep's kind of like a staircase where if you start, you get interrupted on the way down, you got to go back to the top and start again. So you can't just pick up where you left off. So these folks don't enter deep sleep if it's happening often enough. All right. This is just I think it's a 1, 2, 3, 4, about a 2-minute window showing repetitive breathing events. So each circled one is like this is a hypopnea. It's got some airflow, apnea with no airflow. Well, there's a bit of a central apnea here, no effort. Obstructive more there. Yeah, so these repeated events. So basically almost twice a minute, this person's having little micro wake ups. So you can probably, some of these folks will, you might wake them up to go to the bathroom and they think, oh, I haven't slept yet. All right. So the consequences of untreated OSA or sleep apnea is pretty probably out there, pretty well established. Cardiovascular risks, blood pressure, stroke risks, and as we just discussed, hormonal and metabolic, which then can feed back into creating more conditions that are conducive to sleep apnea. Weight gain is also a risk for diabetes. Cognitive fatigue. Now, more recent research is showing some potential links with dementia. Mood is affected. And disruption of sleep routines. A lot of people they end up napping a lot during the day because they're very tired, and that will affect their night sleep and their ability to fall asleep right away and waking up. And so after a while, the sleep kind of starts to happen all over the place, and it, inadvertently affects sleep routines and sleep hygiene as well. And sleep rhythms can also be messed up because of that. And increased insomnia complaints, conditioned hyperarousal, and sleep fear characteristics. So insomnia is kind of really a symptom, I guess. And in the past, we used to classify primary insomnia for whatever reasons, physiological based more. And then there was secondary or psychophysiological insomnia, and that was more you start to associate your sleeping environment as a place to start feeling stressed and worried about, am I going to sleep? You know what I mean? So, and that perpetuates the insomnia. But essentially, they don't make that distinction in the diagnostic categories anymore because it's often a component of many types of insomnia or sleep disorders. So it's sort of kind of a given almost, really. So this is just a little graphic that is very small in the writing. Sorry about that. It is kind of showing how the breathing events cause little wake ups. Then you might hyperventilate during that awakening. You return to sleep, and then the hyperventilation causes some instability in the blood gases that will either reduce your drive to breathe and cause a central apnea, but also sometimes it can also affect your upper airway muscle tone. So it can actually influence how much obstructive breathing events you have too. And we always notice when people are in the sleep studies that the lighter stages of sleep is when we'll see the most events. So if they get to deep sleep when you're titrating them, you think, oh, I figured it out. Well, wait till the second half when they have more light sleep normally, just to be sure. Hypoventilation, then when they're sleeping, and then narrow upper airway narrowing again, and then they have obstructive apnea, and so on and so on. And this eventually, after a while, the whole system starts to people can sometimes be more easier to arouse from sleep, period, which then feeds back into hyperventilating and more instability. And I guess psychologically how you feel that. If you're waking up that often out of a very light sleep, you don't really perceive that you've been sleeping at all. So then you have the insomnia complaint, and you start paying attention to it, and you start, might have some maladaptive cognition, some anxiety about it, and then might, change your behavior a little bit. Oh, I can't sleep. I might as well get up and go watch TV, which is not good because that's blue light, and that will make you have a harder time falling asleep again, and so on. And then, you'd start associating your sleeping environment as a place of, not sleeping. So that's kind of the whole mechanism there. So there's just a little cartoon of, I realized I didn't have anything funny. This is not really that funny, but it's a cartoon. uh, Sort of explaining the whole conditioning of it. Like you start to associate things in your environment with the, not sleeping with hyperarousal, feeling anxious, and so on. And I like this quote, when sleep becomes a struggle, the resulting increased arousal leads to a spiral of negative emotions that are simply not conducive to sleeping. It occurs often in insomnia, not restricted to the prior subtype. That's the previous division of the insomnia types that we used to have. Um, so this has been more recently leading to a new, I guess, diagnosis that they're focusing on called COMISA, which is basically comorbid insomnia and sleep apnea. And at least, 30 to 40% of patients with either have the other. So it's a significant problem. And I like to call it the vicious spiral where, maybe you have some sleep disordered breathing, you start losing sleep, then you might get more overweight and get more sleep disordered breathing because of that. Then your sleep habits, insomnia, anxiety, and all right. So, poor sleep hygiene also has been shown on its own to add to sleepiness, daytime sleepiness, depressive symptoms, and quality of life uh, detriments, and even mild sleep apnea cases. And also having this comorbid insomnia complaint typically is associated with when we try to treat the sleep apnea, people are less likely to accept it initially, and they are often less compliant when they are using a CPAP as well. And more recent studies with using some kind of therapy for insomnia, more so often CBTI, which is cognitive behavioral training for insomnia, in combination with CPAP, definitely improves the outcomes for the most part, or at least will improve people's perception of insomnia. But more recent studies are showing that CPAP adherence is improved as well. All right, so sleep hygiene training is just basically behaviors that are based on, as we've been speaking about, sleep and circadian physiology. Also, cognitive behavioral techniques, which involves educating the patient about sleep, sleep disorders, and also correcting misconceptions about sleep, and stimulus control, which is kind of optimizing the environment so that you're strongly associating your sleeping environment with sleep only. And it has an element of monitoring as well so that you can see how well you're doing, which also helps to reinforce behavior. So ideally, we're going training your sleep wake to the optimal zones in a circadian sense. And by doing that, you're consolidating the sleep. So again, reinforcing that impression that, hey, this is where I sleep. And ideally reducing the time to fall asleep, reducing the time spent awake at night, and reducing the anxiety about sleep. This is just a little graphic. This is not with sleep apnea specifically, but it was a sleep, let's see, what do they call that? Sleep Education for Everyone programs. This is 2025. It's a new initiative that's trying to provide sleep hygiene training in a more accessible way for people. And they monitored initially the sleep hygiene index, which is like a measure of your sleep habits, and they improved. The lower number post-treatment indicates improvement. The Pittsburgh Sleep Quality Index is a popular measure of a person's perception of their sleep quality in a lot of these studies. And again, that's improved quite a bit in the post condition. Sleep duration, the patient's perception of their sleep duration, it's still an improvement, not as high, but definitely at least half an hour or more of sleep. Okay. So what are these sleep hygiene rules? Basically, some of it's pretty common sense, and some of them Kelly was mentioning. A consistent rise time, so getting up at the same time, and also getting out there and seeing some sun or some bright light and within the first hour of waking up is really important to reset your circadian rhythm or to advance it a little bit, so you're not going to bed later. Dim the lights in the evening as much as you can, and definitely stay off the multimedia. I know I see a lot of sleep hygiene. Recommendations where they say, oh, the last hour before bed. And personally, I find like it takes more than that. And I think people vary in how sensitive they are. I'm more of an evening person, which makes me great at being a sleep tech and night shifts, but I'm very sensitive to light stimulation, so I can get knocked off my kilter very easily. Minimize day sleep. Less than 20 minutes ideally, or up to 20 minutes. Usually after that, you start getting into the deeper sleep, and then that can more affect your subsequent night's sleep. Avoiding exercise in the evenings, that kind of revs you up. In the evening, you don't want to go to bed hungry, but don't have like super high fat, high protein snacks or especially high fat, because then you'll end up getting reflux and things like that. But a light carbohydrate snack has been shown also to kind of improve your deep sleep, apparently, and not have too many fluids, so you're not getting up to go pee at night. Keep your room temperature at a nice temperate level. Too hot, you're not going to lose that core body temperature that's typically associated with a deeper sleep. A warm bath in the evening before bed will help that core body temperature kind of fall more drastically. And that seems to be more associated with a deeper sleep as well. Oh, that little arrow is not in a good spot. Whoops. Reduce your amount of caffeine and alcohol. Alcohol feels like it helps you fall asleep, but essentially it metabolizes very quickly. And when it does that, you end up having kind of a rebound effect of a lot of awakenings. And also, if, of all substances, it really relaxes the airway. And if you're going to snore, whoo, you really snore. And it really can worsen sleep apnea quite significantly for those who already have it. So with regards to stimulus control, keep the bedroom for sleep and sex only. And sleep restriction, again, a little star there because depending, but some elements are just involved. Basically, if you're not asleep in 15 to 20 minutes, you should get up and go do something quiet and in a low lit room, ideally. And when you feel sleepy again, return to the room. So you're trying to strengthen that association between the room and sleep only. For someone, there's another some sleep doctors also prescribe very specific sleep restriction for some people who just spend way too much time in bed. So sleep gets very diluted across the 24-hour period and it never feels very deep. They might say, okay, you can only sleep for 4 hours. So they really kind of basically sleep deprive them on purpose so that the subsequent sleep is deeper and therefore not as long. That's going to be up to the doctor's discretion whether that's a safe thing to do. If someone has severe sleep apnea, you don't want to be making them even more tired if they have to drive to work the next day. So with a grain of salt. Consistent bedtime routines to help train your brain. Oh, this is what we do before we go to sleep. It's time to go to bed soon. You brush your teeth, you do all those things kind of in a very regular way to kind of lull you into that sense of this is what's happening next. Some relaxation techniques, breathing exercises, progressive muscle relaxation, meditation, those things help to, if you are anxious in your sleeping environment, to help kind of combat that. Um, and yeah, education is really important. So I really feel it's important to tell people why things are being prescribed. So I find they're more likely to buy into it. And also, there's some misconceptions about sleep. Oh my God, I need to have 9 hours a night. Well, that's not everybody, so don't be anxious about that. Some people are shorter sleepers. It's basically how you feel the next day that's the most important. There's a little graphic there of sleep hygiene that sometimes helps people remember these things better. This is the um, cognitive behavioral training, uh, sort of stimulus controls. We were talking about cognitive restructuring. That's kind of correcting misbeliefs about sleep hygiene, which we kind of talked about. So I always think of sleep hygiene as the whole shebang, but yeah, so it's kind of a variety of elements. So sleep training, now sleep hygiene training, that's the hard part. It's like, who's going to pay for that? So ideally it'd be great to have your sleep center set it all up, but it's not always easy. Although there's definitely an emerging role for sleep technologists. There's a new, I guess, position called clinical sleep educator. There's actually an exam for it now through the BRPT, and that's kind of their job to know a lot about comorbidities and things like that. And then you could have the patients come in and be go through a sleep training program as a group. Cognitive behavioral therapists, obviously the pros at the CBTI techniques. And we have a psychologist here in Ottawa who offers group training, so it's a lot less expensive for people. And there's a little sense of community there too that I think can be helpful. And then there's been this sleep program that I was talking about earlier. That's a community-based delivery. I think they train a layperson in how to deliver that, and they've had some success with that. And there's a lot of self-directed things that some of them are pretty good, and there's some evidence supporting that it's useful and it works. There's books, websites, virtual courses. There's now assistive technology. Fitbits can kind of give you a bit of monitoring and how you're doing. Apps. There's some really good apps, and I have a bunch of them afterwards after this talk, a whole list of them. But I think the most, the important parts of any kind of sleep hygiene training is the why. I find if you understand why do I have to get up early? Why should I not use my phone at night? Once you understand the physiology behind it, it kind of makes it a little easier to begrudgingly comply. And it should be adaptive to the individual circumstances. Again, I was talking about how someone who's, very severely sleepy and at risk for a car accident or something is probably not someone you want to do too much sleep restriction stuff with. Also, if they're, you want to take into consideration, are they more evening types? Are they more morning types? And what you might have to adapt for that. Are they shift workers? That's a whole other ball of wax. And also, I just put a little thing about question mark breathing exercises and sleep disordered breathing, just because we notice in the sleep lab, like with central sleep apnea, and if you're monitoring their CO2 at the same time, some people have very, like, it's almost like I guess their CO2 just dips below the threshold that stimulates breathing. Like they're just inherently have a lower CO2 level to begin with. So those folks, a little bit of hyperventilation upon arousal, it just sets up the next central apnea. So sometimes I wonder if the relaxation breathing might create more hyperventilation that might be a problem. So I think probably if you have somebody with central sleep apnea, you might want to be careful about that. I know my personal experience being on CPAP, my first night I was trying to do these relaxation breaths when I was on it, and it just made me more aware of my breathing and kind of over breathing. And I think I hyperventilated and felt weird. So I'll tell patients that sometimes just try to think about something else, and that might work better for you. Your body knows how to breathe. Don't worry about it. So depending on the person. They should be measurable. So there's a lot of questionnaires and things like that people can use just to, see their progress. And I think that's more encouraging and reliably sourced. There is a lot of stuff out there, like programs, sleep training programs. They don't say who did it and who developed it, and I don't like that so much. So I didn't note them here. But basically, if it's been developed by some sleep medicine, um, you know, center or researchers, you can probably trust it. These are just some assessment tools. This is a hmm, sleep habits assessment. So just to see where people are at, and see how their habits change once they've gone through the training process. So all the references for these are there. Sleep quality assessment. So that's the Pittsburgh Sleep Quality Index, which seems to be used a lot, just the patient's perception of how they're sleeping. And daytime sleepiness assessment, the Epworth Sleepiness Scale. We've seen that a lot. Labs use that all the time. It's more of was to measure severity of sleep apnea. Although I don't know, I find sometimes patients are horribly severe and they rate this really low. But then I think there's maybe like a practice effect. So it might be good for any questionnaire to have people fill it out quite a bit for a while so they kind of get used to thinking about it, and then their ratings become more stable before you use it as your pre. Um, Conclusions. Basically, there's a lot of bidirectional relationships going on to the point where you just get that vicious spiral. But I think it really makes a case for how sleep hygiene training really should be a part of any sleep disorders program, sleep apnea or otherwise. And I think there's a lot of initiatives now, Canadian Sleep Society and in the American version of trying to educate folks about sleep hygiene earlier on. Why not do it in school? Anyway, so there is a bunch of resources for patients here about there's some websites, there are some apps that have been well rated. Even the CPAP apps, apparently there's the MyAir, the ResMed's MyAir app. They can do some ratings with it, and they give a score about how well their compliance is. So there's lots of ways for people to kind of rate themselves. There's supposed to be a pediatric one developing Dr. Lullaby. And then there's some professional resources, I guess. Let's see what else we got. Yeah, I just found that there's McMaster's has a little continuing ed program about sleep. So if anybody wants to train to be a sleep educator or whatever and want to add a little something there, it sounds more like it's more for the person who's not necessarily already working in sleep, but maybe somebody who wants to train to be a sleep coach or whatever, it'd be a good background kind of course for them. And then there's some free online ones offered in Australia as well. And then these are just resources for sleep questionnaires, and then a whole bunch of references that were used for this talk, blah, blah, blah. Thank you so much. I think that's everything.
Fantastic. Thank you, Michelle.
Yeah.
And so for folks watching, we will be sharing the recording of this video so you can go back through and pause and grab those references as well. And certainly if you are looking for them, feel free to reach out to Ambulance and connect those dots. Thank you, Michelle, for
Thank you.
a great talk. One question that did pop up that some questions popped up and then you answered them, so it was very well structured talk. But are you aware of any clinical sleep educators in the Maritimes?
I don't know. I'm not sure. There may be a few folks in Canada who've taken the exam. I'm not sure. I guess it's sort of like, it's an expensive thing to undertake with the jobs not there, but I'm not sure. There may well be. I hope so.
I hope so.
And I know there
Yeah.
might be a few out west.
So there's certainly a need.
Mhm.
We certainly know that there's a lot of sleep apnea in
Yeah.
our province, and folks are needing support in this area. So
Yeah, I was
thank
looking for
you.
you walk. I was looking for stats about that, and apparently they're estimating now worldwide that maybe up to close to 1 billion people may be affected, which is crazy to think
Thanks.
about.
Thanks.
Hmm.
And those and like you talked about, just the runoff effects of not getting good sleep night after
Hmm.
night just has such an impact on our overall health.
Yeah.
Okay, well, we're going to switch gears and go on to the next presentation. Thank you again, Michelle.